Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode, I answered another question in this series of questions from our client Robert. And the question last week was part 2 of my 68-year-old mother is in ICU with gastric perforation, and she's not waking up after the surgery. Will she need a tracheostomy? You can check out last week's episode by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to answer the next question from our client Robert, which are excerpts from email counseling and consulting sessions with me. The question this week is part 3 of my 68-year-old mother is in ICU with gastric perforation and she's not waking up after the surgery. Will she need a tracheostomy? So Robert describes his mother's situation as follows with another series of questions. So Robert writes, "Hi Patrick, thank you very much for your thoughtful answers. So far, her vital signs are looking stable. The hospital team are recommending to do a tracheostomy tomorrow, and we are generally inclined to provide the consent because of the benefits. It will have been 10 days since the last intubation." So the questions for you at the moment that I have are, the hospital, which is ranked as one of the best hospitals in the US, is a teaching hospital, and as such, the consent form states that they can have a resident actually perform the tracheostomy, but with the attending surgeon present at all times. Do you think it's reasonable or advisable for us to require or mandate that the actual operation to be performed by the attending surgeon? Is it even an option? By the way, a couple of answers to some of your previous questions. My mum is 68 years old and she's also a diabetic. I'm also still trying to find out which sedatives she was on as part of the surgery last week. Many thanks, from Robert. So here's my response to Robert's first question today. Hi Robert, I know that the hospital your mother is at has a very good reputation and is one of the top ranking teaching hospitals in the United States. In teaching hospitals, sometimes residents perform the tracheostomy, and from my experience, it would be one of the more senior residents performing the procedure. It's always better to have a qualified specialist perform the tracheostomy, of course. However, the nature of the environment often dictates who is doing what. Do you know if they want to do the tracheostomy in the operating theatre or do they want to do it in the ICU? Most tracheostomies are getting done in ICU nowadays, and as I mentioned in my previous email, it'll be a quick procedure within 30 minutes, done by an experienced intensive care specialist. Therefore, I'm wondering, are they planning to do the tracheostomy in intensive care with a registrar and an ICU specialist present, or are they planning to do the tracheostomy in the operating theatre with a surgeon overseeing the procedure? Also, if your mother is a privately insured patient, you may be able to choose who should be doing the procedure. Check out your mother's level of health cover and the small print. I hope that helps, Robert. Let me know if I can be of further assistance. And then Robert writes back, "Hi Patrick, it does help indeed, thank you. The procedure would be done in the ICU at her current bedside, just as you suggested. They don't need to take her to the operating room. They have said it's relatively simple and will take about 30 minutes. The attending surgeon, the same one that performed the original surgery, will be supervising and present for the entire procedure. We liked her and we trust her. The resident performing the surgery is on the tracheostomy team, so evidently must have some experience. I think we're likely overthinking the resident versus attending surgeon issue, given that this surgery is very common and relatively straightforward. So we're going to talk to the attending surgeon in the morning just to get some last-minute comfort and thoughts and have them to do the tracheostomy tomorrow. Many thanks from Robert. So here's my response to this. Hi, Robert. I think that given the overall situation with a couple of failed extubations, the prolonged stay in intensive care, as well as the emergency abdominal surgery in the last few days your mum had, you and your family are making the right decisions by consenting to the tracheostomy. You have looked into it. You have done some reading and research. You watched some videos and you have been talking to the surgeons and the intensive care specialists. By now you know what to expect, and given that your mother still hasn't woken up, the best course of action is a tracheostomy to reduce or minimize or even exclude sedation and opiates and painkillers, because a tracheostomy basically doesn't cause any pain. Now, if you're still in doubt, check out the following articles and videos where I share more insights about when to do a tracheostomy. The first one you can check out is how long can a breathing tube or an endotracheal tube stay in. The next one is how long should a patient be on a ventilator before having a tracheostomy. And you can also read or watch the following article and video, why would a critically ill patient in an induced coma need a tracheostomy in intensive care? And you can check out what are the risks and benefits of a tracheostomy. I put some links to those articles and video below this video in the written version of this blog. And if you're watching this on YouTube, click on the link below the video that gets you to our website, to those articles. So with a tracheostomy, it increases the chances of your mother becoming more alert, and it also increases chances to reduce or minimize the needs for vasopressors or inotropes such as norepinephrine or noradrenaline or epinephrine and adrenaline to maintain a physiological and healthy blood pressure. By now, you and your family also know that your mother will be way more comfortable with a tracheostomy compared to a breathing tube in her mouth. A tracheostomy also gives patients in intensive care more time to recover in their own time because of less need for sedation, and therefore patients tend to have less desired side effects that is related to the induced coma and sedation. It also gives way more leeway and options to wean your mother off the ventilator in her own time. For now, I really would advise you to go with the flow and to consent to the tracheostomy. It's the right thing to do. So, how can you become the best advocate for your critically ill loved one? Make informed decisions. Get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care. You get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free instant impact report now by entering your email below. In your free instant impact report, you learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free instant impact report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free instant impact report now by entering your email below. In your free instant impact report, you learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability, even if your loved one is dying. You get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You'll get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You'll get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care, and how you need to manage doctors and nurses in intensive care. And it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you check out our blog section as well for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions, or you can call me. Find international phone numbers on our contacts tab. Also, check out our ebook section where you get more ebooks, videos, and audio recordings, and where you can also get one-on-one counseling and consulting with me via Skype, over the phone, or via email by clicking on the products tab. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week with another update.